Hi, my name's Imran Quereshi. I'm the BMJ's clinical lead for quality and safety here at the International Forum, and we're going to be presenting a session on BMJ quality and its activities. With me are Dr. Chatfield, Dr. James Somauroo and Dr. Mareeni Raymond, who also work for BMJ Quality. So BMJ Quality is a fairly new division of the BMJ. Its purpose is to try to improve clinical care within healthcare organisations and institutions through a variety of products and services. And we're going to be talking about some of those products and services today. So just to give some contextualisation to what we're talking about, we know in healthcare there are a significant number of errors that occur, and those errors may be due to systemic failures or human error and other related issues. So really the battle from BMJ Quality side is to try to design and to implement services that are going to overcome those problems. And part of that exists in sharing information and developing new ideas as well. So the first thing I think we'll talk about is the new journal that we've launched in BMJ Quality, which is called BMJ Quality Improvement Reports, which is actually headed by Mareeni Raymond. So Mareeni, can we just have a quick conversation about the Quality Improvement Reports? Can you tell us a bit more about what it is and what its exact scope is?
One of the tools that you get as part of BMJ Quality's workbook is a step-by-step guide to writing up a quality improvement project. So we've all done quality improvement work, which may be in hospitals, in general practice, in the community setting, and perhaps it's not gone recognised. And one of the ways that you can gain some recognition for your work is publishing your quality improvement project in our journal. So after going through the step-by-step guide where you've described the problem that you identified, the background to the problem, what you did to improve the problem and make a change to your clinical environment, and then the results are all presented in the journal. The Quality Improvement Reports Journal is aiming to be the world's largest online repository of quality improvement reports, and already we have about 1,000 doctors, nurses and other healthcare professionals submitting work through this journal. In fact, one of our submitters is James Somauroo, a junior doctor who has used the platform and is going to talk a little bit about his experience of being walked through and publishing a project.
Yeah, I mean, from my point of view, the sort of best part about the online workbook and the online journal is the ease of use. I think, you know, we all have ideas when we're on the wards. So I had an idea for increasing the speed of blood culture analysis. And I just didn't know where to start. But as soon as you log in and as soon as you get to the first screen, it immediately gives you exactly what you need to do, and it then gives you learning modules as to how to do it. So for example, one of the issues that I had was engaging all my stakeholders. And when you get to that part of the project, when you're actually using that to type in how you do it, it then gives you a nice presentation as to how to engage your stakeholders properly. And by doing that and having all the resources at every single point, it just allows the project to run so smoothly and so easily, and actually quicker than you would do by just trying to do it yourself. So from my point of view, the ease of use was the main thing.
And the great thing is that James's project is now available for free for anyone around the whole world to access and be inspired to do a similar project in their own workplace.
And is that the case with the journal, Mareeni? Is it open access? Is it?
Yep, it's open access. Anyone can have a look. If you're not sure about whether you want to engage in the quality process, have a look at the journal and you can see how simple some of the ideas are. It doesn't have to be a big project. It doesn't have to be a big hospital, project involving the whole of your ward staff. It can be something you've done locally. One of the projects James has described as very simple. Another one is handover of the night staff to the day staff, things like that in hospital settings, which is such a simple but big problem, and people have introduced things like proformas and protocols and then shown their work using a quality improvement project, which we hope other people can be inspired by.
And of course we know that actually problems that exist in one healthcare institution environment are almost definitely going to exist and others aren't they? So actually this work becomes eminently shareable, and people can adopt other methodologies used by other clinicians in their own workplace. And obviously we understand that there is a need to adapt those things to local practice. But at the end of the day, I mean, isn't it wonderful that we're not reinventing the wheel and wasting time, and we're actually taking, you know, very strong positive steps towards improving care on a global level? I think that's really good. And James, I just wanted to go back very quickly to the improvement project. I mean, certainly I'll mention bits about it as well, but just from your perspective, there are other tools and resources such as a cost calculator and other things like that. Did you find those useful? Were they of benefit?
Yeah, I think the best thing about the cost calculator particularly is that when you do a project like even the one I did, it's often difficult to actually see the value. And when it's something such as saving money, it's always difficult for you to calculate it. You don't know how much things cost. You don't know what a bed day costs, whether it's worth saving a bed day. And when you're a junior, you often think it's more of the consultant's role to take care of those sorts of things. But often, when you make changes that improve the quality of patient care, you're actually saving money as well. Now, what the cost calculator did for me is that although I was discharging patients quicker, from my point of view as a junior doctor, it was making my patients feel better for getting out of hospital earlier. But the cost calculator allowed me to see that actually I was saving over £80,000 a year in bed days, which is something that I wouldn't have necessarily known, but actually gave my project a lot more weight, and just made me feel a lot prouder as well. The resources, right from the beginning, right from the introduction resource, right the way through, they're all extremely useful, and they make everything run a lot smoother and a lot easier.
Yeah. And I suppose, Marie, just following on for that, in terms of the journal, that obviously has significant implications for the developing world in particular. I mean, as we know, the quality platform and the Quality Improvement Reports journal are accessed by countries all over the world, including places like Malawi, where I'm sure that there are significant challenges in improving healthcare. So, I mean, I'm sure that you must have some experience about from the point of view of the journal.
There's one wonderful project which came in, was one of our earliest projects submitted, which was from Lahore in Pakistan, where a junior doctor had identified a problem in that sort of, I think 90% of the patients attending a hospital were illiterate, and when they were given their discharge medications written down on a scrap of paper, they didn't understand the dose, they didn't understand how to take their medication because they couldn't actually read the instructions. So this doctor had a great idea. He created a TTA, that means a medication list, which used symbols to show night, day, time of day, how you're supposed to take the medication using pictures. And he improved the compliance and concordance with use of medication according to the instructions the doctor had given massively. And this was a very simple project, which and shows, as you said, Imran, that this toolkit can be used anywhere in the world.
Yeah, absolutely, and I think it's interesting because we've had some comments back from that particular project saying that actually, whilst this was done in the setting of a developing country, actually it may be applicable in the developed world as well, because we have patients who, may have cognitive impairment, or maybe in the elderly who have got other difficulties, that it may be applicable here. So it's interesting how that would translate as well, I think. And I think I want to bring the discussion a little more to Kat now, really, and to talk about something else that we've been developing within BMJ Quality, which are the clinical quality improvement products. I mean, there is obviously a national strategy within particular areas of healthcare, and particularly looking at the long-term conditions such as diabetes and dementia and COPD. So would you like to talk a little bit about that and just explain what we've been doing?
Sure. I think the Quality Improvement Workbook, as is very much designed for individuals, and they can bring their own ideas and work on projects. Like James had a really good idea and was able to work on it. But we know that lots of organisations, especially primary care, are being given lots of aims and targets that are much more strategic and national. And the idea is that with the clinical programmes, we're helping them to get a handle on how they can approach improvement in those areas. So as you said, particularly COPD, dementia, and diabetes. So the workbook is not just a blank space that they can fill in. It's full of evidence about what's the best practice, what the guidelines, what are the standards they should be aiming for, the ideas for how they can interrogate their own data to see how they're performing, tools to do that, and then tied in with practical step-by-step guide to what they should be doing to get up to those standards. And then all in the same template that's used for the individual workbook, and all completely available to submit and publish as a project. So a really straightforward way for busy clinicians to get the improvements that they want to see for their patients in some really key conditions.
Sure, and fortunately you're a GP by
yes.
profession. So, and from your perspective as a GP, as a practicing GP with your GP hat on,
Yeah.
you know, how do you think that this? Do you think this is going to significantly improve care of patients?
I think so, and I think time is always an issue. I think initially the workbook can look like it's going to take time, but actually it's very time saving because it does all the background work for you. So all the preparatory work that goes into a project is already done. So actually you can get straight on to the doing and the changing and improving and making a direct impact on patient care. I think the other thing that I really like about it as a GP is that it's not just for the GPs, it's for the whole practice. So you can have the practice manager, the nurse, the healthcare assistant, the GPs, all working on one project collaboratively and doing their bit. And that's really how a primary care team works. So I think there's a huge potential for maximising everyone's role and actually spreading the burden of that work more effectively through using the workbook.
Excellent, and clearly this is where there's an integration between the clinical QIPs and the journal, because the work that is done by general practitioners and their colleagues is then submitted to the Quality Improvement Reports journal. And maybe, Mareeni, you know, yourself being a GP as well, maybe you want to touch on how that is going to sort of, if we're looking at it from a bird's eye view of the information that's being submitted, how that's going to be of benefit from a national perspective and not just a local one.
Yeah, I think we've developed quite a few quality improvement projects which are all, as Kat said, meeting guidance nationally, like the National Institute of Clinical Excellence guidelines, but it also meets your criteria for QOF and enhanced services. We've tried to make it the sort of project where you're not going to be doing your work twice. It's going to be covering all the bases that GPs and other practitioners need to be covering. And hopefully at the end of doing a project, you will have a publication. In fact, you will have a publication which shows that you've either improved care or not made a difference. We don't mind if you haven't made a difference. We want to know if it doesn't work. So we want to know what these projects are doing for clinical care. And when we have a lot of projects, we'll be able to compare, we'll be able to collate that information and see what we need to improve on nationally, hopefully, if everyone does engage with the project. And it doesn't have to be a doctor that does it, as Kat said. You can engage your registrars, junior doctors, people who need to have publications for their CVs, and doctors who are interested in academia who would like to get a publication would also relish the chance to have a go at it. And as James has said, it's really easy to use.
I think one theme that's coming up very strongly from all of these things is this issue of sharing and, you know, people using resources sort of together. And I think that brings us nicely onto this to what we've just launched within BMJ Quality, which is the community. And I just wanted to get actually all three of you some perspective about, you know, what you consider the community to do, how you think it will function. So maybe actually if we start with Mareeni again, just work our way down and your perspectives on the community, really.
I think the community really reflects what we're trying to do with the BMJ Quality platform. It's exactly what we want to do. We want to be sharing information with different people around the world who are trying to achieve the same goal, improve the quality of care for their patients. So the community board is basically like lots of online platforms that are used in terms of social media, a chance to discuss things, to find other experts in a field, to find somebody doing the same thing, to find somebody doing something different that you want to get an idea about how they're doing it. It's just a way of communicating with lots of different people who are in the same, who care about improving quality.
And James, from your experience as junior doctor and the community, do you think that this would be a force for change between junior doctors? Do you think that it would get them excited about quality improvement?
Yeah, absolutely. I think once you engage in a project yourself, you're quite happy to see other people that are engaging in similar projects with you, even to the point where you can actually go out and engage people. So, for example, I engaged a finance manager, went to go and speak to her. She was very excited by the project and by the savings that I was projected via the cost-saving calculator. So that ended up engaging her into my project, got her into the community. And similarly, she told her colleague. So it is a way of just us all kind of engaging each other, and it's that sense of community, I think, that's quite nice. It's the sense that you're part of a website, a workbook, a journal that similar-minded people are part of. The ability to search for projects that are of a similar vein to yours, see what's worked, see what hasn't. You can end up messaging those people and ask them why they think it didn't work if it's not written in their project already. And again, it's that sense of community that you just feel that there's so many people doing similar things, right or wrong, that are all just going in one direction together, which is excellent.
And Kat, really from a general practice perspective, I mean, general practice, in a way, is it's a very local specialty, isn't it? It's often, you know, GPs often say and feel that it's just myself and all my partners around me, but there's no real sense of networking between different practices, and obviously we've got clusters and CCGs and other bits and pieces now, but what do you think the community will bring to general practice?
And I think it's really what James and Mareeni have said, it's that sense of shared purpose. And if we look at lots of the evidence about what motivates people to do improvement and change, it is about shared purpose, shared energy. And I think sometimes in primary care you can end up feeling a bit isolated in your own little island. So actually linking in with other people is incredibly important to drive you forward, and you know, when things are not going very well, to be able to troubleshoot and discuss and reflect outside the boundaries of your small organisation is really important. Also, I think as practices are going to move to a more federated working model, and then for practices to be able to work on projects together across practices, that's also going to be really helpful and really powerful.
Excellent, excellent. I think, you know, one thing that we maybe missed as part of the discussion is talking about, you know, the actual platform that we've developed over the last year in BMJ Quality itself, and I think that in a way is sort of the root of many of the things that we've already spoken about. And I think what I find particularly fascinating about it is, as James has already mentioned and Mareeni's mentioned, you've mentioned as well in passing, that it really does structure the way that people think. I mean, certainly I know from doing lots of quality improvement work and mentoring junior doctors for a few years now, that it's often difficult, and maybe you'll give me some of your reflections as well about this, to get some standardization. You know, if one group of my junior doctors is doing something and another group is doing something else, they'll be doing it with a completely different methodology, and then you sort of sit there scratching your head thinking, how am I going to demonstrate particular outcomes, or how are we going to get to a particular focus? But what I found is really nice about the platform is that it takes you through its three sections of, you know, the introductory part, identifying your problem, going through the background research, doing your baseline measurement, then the actual second section about the doing part of it, getting your results, and the third part about analysis and review. And I think, you know, it's based obviously on the Squire guidance. We know that that's a particular set of guidelines which have been developed for quality improvement, and we've adapted them slightly for BMJ Quality. But I think that its sheer structuredness has given us, or given the healthcare community at large, a really positive way of engaging with quality improvement.
I think it's, as James said, it gives you somewhere to start. You've got a really good idea, but you don't know what to do with it. And then the workbook basically tells you how to transform your idea into reality for patients. And I think that's really, really helpful in terms of the structure. And the other thing you just reflected on, as Mareeni has with the journal, is that makes them comparable. So actually, when you want to, in 6 months' time, look and see all the projects that have worked on handover, you can make some direct comparisons between those projects, which is much more powerful in terms of getting the data and big numbers to know what really does work.
Absolutely, yeah. As something I thought it's important to reflect on, and you know, this. You know, many people find it slightly amusing, but it's related to the cost, excuse me, of using the platform. In the cost of the platform, as we know, is £49, and again, your perspectives would be really interesting in this, because, you know, when you speak to other junior doctors, I mean, you say the cost of using the platform for a year is £49, and there is borderline shock and horror at the suggestion that I as an individual may have to pay £49 a year. I mean, bearing in mind that gives you access to the platform for a year, and you can publish as many quality improvement projects as you wish in that year as well, which means that you may get a potential equivalent number of publications within the Quality Improvement Reports journal. So, I mean, what are your thoughts about this? Because, you know, it's one of those questions which I think that is important for our audience to realise, you know, why we're at this point. Mareeni, maybe do you want to, or James, one of you want to?
Well, I think James would agree that it's very daunting when you have a lot of work that you've done to try and think about publishing it. It's very daunting, and you know that you often do get rejections. Our journal, it's not daunting, and I think it's very hard. We keep saying it's so simple and easy, but actually it's very hard for us to show you how simple it is. If you go to quality.bmj.com, you will see videos which walk you through which will tell you what to expect and tell you how simple it is. I think that's one of the reasons why I think paying £49 is actually a very small amount. You're getting walked through and getting almost a 99% guarantee of a publication within reason. and you'll be able to share your work with this community. You'll have access to the online communities, the learning modules, and we had to choose between making it an online access journal or asking people to pay to join the platform. And paying £49 is much cheaper than if you had to pay for a journal subscription, as we all know. So I think it is, for a junior doctor, it can seem quite a lot of money, but actually, if you consider what you're getting for that, it's a lot. And for larger organisations, we do subsidise that price as well. So it's not just on an individual basis that you can buy the subscriptions.
And James, £49 from your bank account, you know, how does that feel?
Well, not great. But no, in terms of, as I agree with Mareeni, in terms of what you get for that price, it's invaluable. You can't really put a price on how good it is to have the walkthrough as easily and as accessible as the BMJ have made it in this workbook. It really is worth it. And as Mareeni said, you can publish as many quality improvement projects as you have done previously, as you are doing now, as you want to do in the future for that year. So there's an infinite amount of potential publications that you can get, which I'm sure you guys know as well as you've worked through. Publications are invaluable. And, you know, just the ability to actually get walked through the ideas you've had and see the results as measurable outcomes, it's excellent. £49 is not a lot for that when you actually tally up what you get at the end of it.
Well, I think a lot of junior doctors aren't really aware that most open access journals require a fee for submission, because that's how they stay viable. So I think, as Mareeni said, it was a real choice to have these reports available to everyone as a really good repository of best practice for people who aren't going to use the platform but who are still going to be doing quality improvement. So I think that's one thing. And then, as I said, they might not be aware that you often have to pay to submit to an open access journal. And I think the other thing is the sort of learning resources. Like, you know, we're used to paying for courses and for learning modules, and there's, you know, over 20 hours of e-learning on there, which is valuable in itself. And if you're going to go on a course about quality improvement, like a half-day workshop, you'd be paying well over £49. So I think that's really good value. And the other thing I want to say is the mentoring as well. You know, the access to that sort of expert pool of resources is invaluable.
Absolutely, and needless to say that, you know, when you've done a piece of work, and let's now look at we consider time after the quality improvement program, and if we look at, you know, the time before that, if you wanted to write any particular type of paper, you'd have to sit there thinking, what are the headings, how do I write it, what is the structure, what is the format, what is the spacing, and all of these really technical issues. But what I love about the program is that once you filled in your online workbook, all you do is you press one button and it automatically generates this paper for you, you know, exactly as you would need it, and, you know, it automatically gets submitted. So I think that, you know, what we've managed to do is to take a lot of the work out of publication for people. And I think that it's, you know, people may turn around and say, well, it's very easy to submit, but I think it's important to remember as well that it does go through, you know, a double peer review process, of course, you know, and the other things is that this will very soon become, you know, a PubMed indexed journal. So it is just like any other journal in that sense. But, you know, I think from my perspective, certainly, putting it out there, making it open access, really, the whole point of it is to be able to empower people, is to be able to share knowledge, is to be able to really get quality improvement out there. And I think that, you know, that's the raison d'etre of the journal itself. So I think that's an important point.
Kat mentioned the mentoring. We haven't actually mentioned that before. Do you want to talk about that a little bit more?
Yeah, Imran, do you want to? It's your brainchild.
Well, I mean, I think certainly from my perspective of having, as I've done quality improvement with junior doctors before, I've seen both sides of it. So junior doctors sort of left on their own to their own devices, trying to get on with the project, and those who have been not handheld as such, but given sort of gentle advice along the way. And certainly there is a marked difference in somebody who's being mentored as opposed to somebody who's not doing it, because obviously you don't understand the institutional issues as well. So what we've done in the BMJ Quality Improvement Programme is to allow a local institutional mentor to connect with their junior doctor. So if I'm doing a project and Kat's my mentor, then I can ask Kat to join me as my mentor on the platform. And what that will mean is, whilst I can enter all my information onto my workbook, Kat as my mentor will come along and log in through a mentor login, which interestingly is free. We don't charge mentors for being mentors on the programme. And she'll be able to see all the work that I'm doing and be able to advise me through our internal messaging system that, Imran, maybe you might want to consider changing this, or this is great and maybe we could do some more work on this. So, a dynamic thing. And really, when we were developing the mentor system, I think we were conscious of the fact that, mentors don't have a lot of time, so we need to develop a rather robust way for mentors and mentees to communicate. So I think that we've done that fairly well. Obviously, nothing's perfect, and things are always in progress. But I think that at the moment, fits the bill very well. And of course, we will, subject to people's advice, continue to improve that. So absolutely. And I think, probably rounding the whole discussion off now, and I'd like to thank all three of you for your input, really, is that BMJ Quality is clearly developing lots of services. So we've got our quality improvement program, we've got our clinical quality improvement products for general practitioners, we've got our quality improvement reports journal, and all of these three are working in harmony together, trying to promote the message of quality improvement. We are trying to make this as accessible to frontline clinicians and all healthcare professionals anywhere in the world, given that we are in so many different countries already. And the hope really is that people will take up the mantle of quality improvement and really make a difference to healthcare. Thank you very much.